Hello, anatomy colleagues. This is Dr. Alsip, and in this video, we will be discussing the bones of the thoracic cage. So we will describe each one of these bones and major structures and focus in on some of the clinical relevance for some of those specific structures. All right, so the thoracic cage, which is sometimes referred to as just the rib cage, is composed of ribs, as I just mentioned, as well as their associated costal cartilages. That's what is indicated here next to the sternum. Then you have that sternum most anteriorly placed, and then most posterior, you'll have thoracic vertebrae. And these bones surround the thoracic cavity and serve to protect the visceral structures that are within the thoracic cavity. So things such as the heart as well as the lungs, they take up the majority of space. So let's start anteriorly with the sternum, which colloquially is sometimes referred to as the breastbone. And there are three parts to the sternum, and we're going to start from superior to inferior. So the most superior part is going to be the manubrium, which means the handle. The body is intermediate and the longest portion of the sternum, and then the most inferior portion is the xiphoid process. So let's discuss structures on each one of those parts. And there are going to be three parts on the manubrium that are palpable. So we can actually palpate them, and that can help you in terms of physical exam. So the most superior and also mostly midline structure is the suprasternal, or sometimes you will hear it referred to as the jugular notch. So this is right at the top of the sternum. It's that divot that you can palpate right there. Now, if you find that jugular notch and then move laterally, you will be able to palpate where the clavicle meets the sternum, and that forms the sternoclavicular joints. So the bony part on the sternum is called the clavicular notch, and that there's going to be one of these on each side. So those are all very superiorly placed on the manubrium. Now, if you return to the jugular notch and move your finger inferiorly, you will palpate a slight anterior projection, and this is caused by the articulation of the manubrium to the body of the sternum. And this region or this area is called the sternal angle. And this is a really clinically important area because number one, you can palpate it. And if you are at the level of the sternal angle, you know that you are at the level of the second costal cartilage and its associated rib. So knowing that you are at the second rib level means you can count ribs and intercostal spaces from there. And this can be used in physical exam. This can also help guide you in terms of the placement of the stethoscope for auscultation of heart sounds, as well as your heart valves. So this is something that you will return to over and over again in your clinical practice. Now, the body of the sternum, as I mentioned, is the longest portion, and on its lateral side are numerous notches where the costal cartilages of the ribs will actually attach to the sternum. So that's that anterior attachment there, and that will be on both sides. The xiphoid process of the sternum is the most inferior portion. It's also the most variable portion. Not all xiphoid processes look the same. It may not even be fully ossified or fully bone, even into adulthood, and that isn't necessarily pathological. It's just a variation that occurs. And there are other variations that can occur with the xiphoid process. It could be bifid, meaning that it's kind of two different parts or split into two different parts, or it can even be curved. So usually when it curves inward or posteriorly, and you don't want it to curve too far inward because there are important structures there. Now the ribs, as we mentioned, attach to the sternum anteriorly, and they also articulate with the thoracic vertebrae posteriorly. So they're really forming that bulk and kind of closing off the thoracic cage. They're these kind of horizontal bars. And these are relatively flat and light bones with varying amounts of curvature. So depending on what level of the cage you're at, So very curved superiorly and then decreases in terms of curvature the more inferior you get. There are 12 pairs of ribs, meaning that there are 24 in all. And that first rib, rib number 1 will be the most superior, rib number 12 will be the most inferior. Rib fractures are relatively common, particularly when we're talking about thoracic injuries, and they can vary in terms of severity. They can be relatively mild, so not too big of a deal, or they can be rather severe with fractured parts displacing considerably, and the complications may arise as if that fractured segment will damage the deeper structure. So that could potentially cause a tear in the pleura or even in the lungs that could lead to a collapsed lung. So there's a great deal of variability in terms of severity of rib fractures. Lastly, the most posterior bones of the thoracic cage are the thoracic vertebrae, of which there are 12. That matches up with how many pairs of ribs you have, right? And as I mentioned, the ribs do attach here, and they actually do so in 2 different places. And where the ribs actually attach on the vertebrae are called costal facets. And these, if you see a costal facet on a vertebra, which is really just a smooth area on the side of the body or the transverse processes, this means that you are looking at a thoracic vertebrae rather than a cervical or a lumbar because it is only the thoracic vertebrae that have costal facets. They are the only vertebrae that articulate with ribs. You can see right here the head of the rib articulating on the body and the tubercle of the rib articulating on the transverse process. All right, excellent. We have reached the summary slide, which is an excellent place to review and gauge your understanding of these concepts. Please reach out if you have any questions, and I hope you have a great rest of your day.